Good morning to everyone.
We're going to go live in about 2 seconds. We're in a kind of a practice mode now, but we're about 7 minutes from our start time, and we're going to let the audience come in now, if that's okay.
Thanks, Ray. So just everyone remind that if you're not presenting, please keep your microphone muted. Thank you. And I will announce each of the presenters. Are you at the beach, Luis?
I'm trying to keep warm.
Watch out for high tide.
Yeah, it's too hot here in Colorado right now.
Global warming really took over there.
Yeah. When are you coming, Ray?
When am I coming?
Yes.
I love Colorado.
Yeah, you are invited always.
Good morning, everyone, and welcome to our International Colorectal Web Meeting. Today, I did not have a time to get a list of all countries joining us, but I will try to get it as we go through the meeting. So if you can just please type in the chat the country you're joining us from, I'll be sure to acknowledge at the end of the meeting. So the first presentation will be by Dr. Holly Neville. So welcome, Dr. Neville.
Sorry, so many years of Zoom, I still have trouble getting off mute there. So let me just make sure that I have this presentation mode. I don't think I have it in presentation mode. So sorry. Okay, I hope you all can see my presentation now.
Oh, we can. Can you go back to the first slide?
I believe on the first slide, this one.
I'm looking like you're on slide 10.
Interesting.
Hold on.
Let's stop sharing because I have it on slide 1. Okay, I'm going to try to share again. Am I on slide 1 now?
Yes, you are. Yep.
Okay, wonderful. So I really appreciate you all letting me present today. I have a difficult case that I appreciate your assistance with. So the patient is currently 3 years old, has been full term, and he was diagnosed at birth with viral. At birth, he had usual evaluation, an echo with a PF, renal ultrasounds, which were normal. He was noted have bladder stones. Spine sound was normal. He had inverted anomalies. He was diagnosed at Al's Hospital with a high imperfectness with a high bladder neck. At birth, he underwent multiple surgeries in the first year of life. I have the opportunities for all of these, for most of these, not all of these. Initially, he underwent a laparoscopic assisted colostomy. This was an colostomy with Altman's pouch. This was complicated by retraction and was redone with colostomy revision.
Dr. Neville.
Yeah.
The slides are not moving, at least for me. I just see the first slide.
And somebody's talking.
My gosh. I don't know why they are moving for me just like normal.
Ray, can you upload the presentation and you move the slides?
I'm gonna Ray, do you have it? Okay.
Do you want to start here or the next slide?
We can go to the third slide, please.
Okay. How's that?
I just see the slide.
I'm sorry, I didn't understand.
I only see everyone else.
Do you see the one that says move to another state and present it to us with?
No. This is quite perplexing.
You try it again. How about now?
I see it not in presentation mode, and I did case 1, Holly Neville.
So you see the first page, the title page. Do you see the second slide now?
No, I do not.
So
No,
the
it's just
way
slide
it's
one.
showing, it's not showing as presentation mode. So we see one slide and we see several slides, but for the audience, the slides are not moving.
No, which really doesn't make any sense. It's quite bizarre.
Ray, the presentation is frozen in the slide number 1.
What slide are you seeing right now, Luis? Are you seeing
Number
the male
1,
patient?
number 1.
Number
We
one.
all see
Yes.
the case number 1, and then all the little slides on the side.
Okay, hold on. What about now?
Slide
It's
number
the
1.
same.
So you can't see the slides moving at all?
No,
No,
no, Ray, it's frozen in the slide number 1.
Okay. I don't know why this is going. It's moving for me here.
I think that's what happened with Dr. Nabil too.
Try to close your PowerPoint.
It's a completely normal presentation, but nothing.
Would you want to try your share again, please?
Sure thing.
Now,
Please tell me.
when you clicked, we can see slide number 3 in the main. So I think if you
Okay.
try to see if you click on the side ones and see if we can move.
Yeah.
No,
Am I changing slides?
no, it's staying on slide number 3 now.
Oh my goodness. Well, let me go through slide number 3, and perhaps if I stop sharing and I pop up slide number 4, we'll be able to share the discussion. Because slide number 3 has the bulk information. So the patient came to me with the history that you see here. Again, I don't have all the full operative reports. I have the majority. He had a colostomy that was an end colostomy with a Hartman's pouch. This retracted. He had a redo colostomy with a standard double barrel colostomy. At that point, after he recovered from this, he went a laparoscopic with a black fish, and at the time had a diverting ileostomy. At that operative, it was an operative report, but having told me the distal limb of the ostomy was of inadequate length, and they had to do this and pull through some sort of blood supply. Because then later under rectal examination, where they found some ischemia, they redid a PSARP shortly thereafter with QOD. Then had and closure with anal dilation and endoscopy. He came to me and joined a series of examinations. I stopped sharing, advanced, try to share again. So when he came to me, I gave a new slide.
Ray, the sound is really bad. I can understand.
Yeah,
I think that the internet is not very good right now at Holly's site.
At the hospital where you have quite good internet, but let me try to disconnect and perhaps proceed with another case and I'll sign back.
okay, that sounds like a good idea. That'd be great if you could do that. That might be the issue we're having here, so. Although I don't know why mine didn't get moving forward, but anyway.
Okay, so we're gonna try to move to the second case, and I apologize, we never had this problem before, but if it doesn't work, if we have trouble again, I think we'll just stop the meeting because we cannot hear, the slides cannot work. So we'll try Dr. Carolina Giraldo and Dr. Carla Santos. Let's see if your presentation works. If it doesn't, then we'll just cancel the meeting.
Good morning. My name is Carolina Giraldo. I'm colorectal pediatrics here in Institute National of Pediatrics in Mexico City. Today, I'm going to present a case of a 10-year-old boy with unspecified anorectal malformation. At the referring institution, he underwent the following procedures: sigmoidectomy with proximal colostomy and distal Harman's. Posterior sagittal anorectoplasty done at 1 year old. Then colostomy closure, but with subsequent perforation and enteroatmospheric fistula few days after the colostomy closure. Ileostomy and mucous fistula was done after. In this picture, we can see his clinical aspect, many scars in his abdomen. We identify 2 severe stenosis. The first 2 centimeters above the anus, and when we introduce a head dilator number 12, we identify another severe stenosis, unable to progress this head dilator beyond 6 centimeters. So this patient had double rectal stenosis. This is distal ileogram. We can see double rectal stenosis by the blue arrows. This patient had a sacral index of 0.8 that was normal, and a renal ultrasound with normal kidneys and bladder. The operative, we performed a rectal examination and identified a fibrotic ring 2 centimeters above the anus. We started with posterior sagittal approach and a 180 degrees rectal mobilization, surpassing the distal rectal stenosis. Then we perform a laparotomy with lysis of a rectum. In this video, we can see the dilated proximal colon. Later, we identify the pelvic rectum. Later, we identify the pelvic rectum from above and perform a longitudinal incision, identify the second stenosis, 2 centimeters distal to the incision. We remove this second stenosis with a 22 millimeters circular stapler. As you can see in the pictures, we introduce the circular stapler into the anorectum and the angle from the incision above until pulling together, creating an end-to-end anastomosis. After this, we could easily introduce a number 18 head dilator. In this picture, you can see it coming from below. A transverse incision in the proximal dilated colon was performed to construct a diamond-shaped anastomosis. The proximal colon had purulent content that was drained and irrigated after. Then a terminal rectum colon anastomosis was done, diamond-shaped. In this video, we can see both ureters, the left iliac artery, rectum, and proximal colon before the anastomosis. Finally, we complete the anorectoplasty. We left a Penrose drainage in the posterior sagittal incision and a transanastomotic 22 French Nelaton catheter for 7 days. The patient had a good postoperative course without complication. He is on rectal dilatations before closing the ileostomy. Thank you so much for your attention.
Thank you very much, Dr. Giraldo and Dr. Santos. I think now this presentation worked. Congratulations. We always say we don't argue with success, but I'm just going to discuss as an option. I think if I had this patient in front of me, instead, since the distance between the two strictures, the lower stricture and the more proximal strictures was not so much, I think instead of using a stapler, I would just have brought more proximal colon down, because having a stapler line so close to the anus, I understand this patient probably won't have bowel control, but especially if we're thinking about a patient that will have bowel control, that you have normal sphincter, you have almost like a distal obstruction and a staple line very close. So I would be nervous to do that, but I am glad it worked, and congratulations. Do you have any comments? Any questions or comments from the audience? No? Okay, so congratulations, Dr. Giraldo, and congratulations, Dr. Santos. We're gonna move to the next case that will be presented by Dr. Lisa Raga from Hospital Infantil de Mexico.
Hi, good morning. Good morning. Today we're gonna see a case of a female of 70 years old who born with a cloaca of 4 centimeters of common channel. She has an acquired absent distal vagina, fecal incontinence with sacral agenesis and renal agenesis. In the background, she has a colostomy as a newborn. At 18 months, a PSARP and abdominal urogenital separation. Proximal vagina was closed as a Hermann pouch and ureterostomy. At 3 years old, a colostomy closure, and 5 years, a bladder augmentation and Mitrofanov. Seen at our institution at 16 years, she has medical management to inhibit menstruation with leuprolide acetate, and we decided to do examination under anesthesia. We can see in this picture that the patient has no vagina and no urethra. In the X-ray, we can see the sacral agenesis. And we do MRI. In the left, we can see the bladder. And in the right, we can see a rudimentary vagina and a dilated rectum. So how would you approach this patient? Transanorectal anterior sagittal approach and proximal vagina pull through, total vagina replacement with bowel, or vaginal replacement with distal rectum. Okay. Well, thank you. We decided to do a vaginal replacement with distal rectum. The patient turned into the prone position with pelvis elevated. The genitalia and perineal area was properly pressed. We placed 5/0 silk stitches for reference around the rectum and then start with a sagittal incision until the rectum is completely dissected. And then we pull through the rectum above the perinatal reflection. We continue the anterior sagittal incision until we found the proximal vagina. We placed 5 silk O stitches, and then we open in the middle and drain the vaginal content. Then we check the irrigation of the rectum and start splitting to make the vaginal graft. We tubularized the vaginal graft. It was about 8 centimeters of length and closed the lateral wall of the rectum with 4/0 bicrop stitches. We placed the vaginal graft and made a terminal anastomosis of the graft and the proximal vagina with 4/0 bicrop stitches. Then we made the introitus and checked the radio of the new vagina with a Heger 16. Finally, we placed the rectum and made the anoplasty and closed. This was the final result. And the patient is scheduled for the next month for exam under anesthesia, and she will be in the bowel management program. Thank you.
Very good, and congratulations. I think the technique that you use for this neovagina was splitting the rectum and tubularizing. So whenever those techniques, whenever the patient has no bowel control, usually I just use the distal rectum, the full distal rectum, so I don't have to split and then anastomose to the upper vagina. But what you did just, I think she had a very dilated rectum, was a very good option too. And she had what seems to be an adequate vagina. For those patients that are older, for young patients, we never do vaginal dilations, but for patients that are older, especially if she's mature, if she's interested in having intercourse, then we advise them to dilate to avoid the need for a future operation. Just like in the anoplasty, that the introitus will have a tendency to narrow. So for this older patient, I would advise dilation. So congratulations on your case. Any questions or concerns from the audience? Do you want to comment?
Congratulations, doctors from Hospital Infantil de Mexico. Obviously, you are now dealing with complex reoperations, and those complex reoperations should be done in institutions like yours, not in any other place, because they are rather sophisticated. So congratulations, because you are getting into the dealing with the consequences of bad operations at the beginning. But that's your job. You decided to become super specialized, so that's very good. You selected very well to take a piece of rectum in a longitudinal fashion, but the only possible consequence of that is that the vagina looks rather narrow, so you have to start moving toward dilatations, because it looks from here very narrow and but very good blood supply. To make that separation of that longitudinal division of the rectum is a sophisticated maneuver, because you have to preserve the blood supply of both the rectum and the vagina. And that, not everybody knows that, because you know that the rectum doesn't have a real mesentery like the mesentery of the colon. The rectum has something called mesorectum, and that's a bunch of fat that surrounds the rectum, and you have to separate that. And I didn't show exactly how you did it, but obviously if that piece of bowel survived. So congratulations, it's very good.
Thank you.
Let me see if there is any questions. what are the options for bowel management in such a patient? So those patients that don't have bowel control, they need enemas. So after an operation that you have longitudinal stitches, I would say we wait at least 1 month before starting the patient on enemas.
So the question is how much colon was left. In other words, you did everything posterior sagittal, but the patient has ascending colon, transverse colon, descending colon, because if the patient has a short colon, then the bowel management, as you know, the modality of bowel management will be different because then you have to use only saline enemas, constipating diet, Imodium, and so forth. Whereas if the patient has the entire colon intact, they just need the regular enemas, and by trial and error until you find the one that cleans the colon.
I'm assuming the patient has normal colon, right?
Yes.
What about
Yes.
appendix?
Does she have an appendix for a future Malone? No
No.
appendix?
She
Oh, they
has
did
a
mitrophanol.
mitrophanol.
That's right. That's right.
The urologist came first. You should always be first, okay?
Yes.
So Dr. Neville, let's try again your case. Hopefully we have better luck now.
Okay, first, can you hear me better now?
Yes, for sure.
Yes, much
Okay.
better now.
All right, I switched this all over to my private side versus my university side, my memorial side. So let's try this and see if it works. I sure hope so. Okay, are you able to see my slides this time?
Yes,
Okay.
perfect.
And how much, and they're moving?
Yeah.
Okay, would you like me to start from the beginning?
Yes, please.
That's
Okay.
good.
So this is a patient that I had referred to me when he was 3 years of age. So I saw him recently, just several months ago now, and I'm really grateful for your assistance in this case. This is a full-term male who was born at an outside hospital and diagnosed with Voctral. He had an echo with a PFO. His kidneys were noted to be normal. He did have some bladder stones in the first year of life. Spine ultrasound was normal, and he was noted to have some rib and vertebral anomalies. Additionally, of course, he had imperforate anus. This was believed to be a bladder neck fistula. His surgical history, all within the first year of life. He had initially a laparoscopic assisted colostomy. This colostomy was an end colostomy with a Hartmann's pouch. This was complicated by retraction, and he underwent a colostomy revision. The colostomy revision was a double-barreled colostomy. After he grew somewhat, it was decided for him to go for his laparoscopic assisted PSARP, and they noted a bladder neck fistula. However, the distal portion of the colon, it seems, was of inadequate length for the pull-through procedure, and they needed to do an anastomosis prior to the pull-through. He did not have normal function after surgery, so they did a rectal exam under anesthesia and found him to have an ischemic segment. They redid the PSARP, and the ischemic segment was thought to be due to the anastomosis of from the colostomy that they needed to close. I forgot, he had an ileostomy to protect the PSARP at that time. He then underwent several anoplasty revisions over the course of the next month with rectal exams under anesthesia, and then finally underwent a major debridement with a wound vac placement. The parents have pictures they have shown me that show a large open posterior wound with wound vac exchanges. And then he had a cystoscopy with bladder stone removal. So after these procedures and several years passing, he came to me with a complaint of ongoing rectal pain, and an outside physician had seen him and thought that he may need to have his surgery redone. So he comes to me with anal inflammation and skin breakdown and fecal incontinence. I believe this is your survey slide.
Yes. Do you have a poll, Ray? Perfect. So everybody can vote. What would they like to do if this patient was in front of you? We can get the answers. Majority said all of the above. Rectal examination under anesthesia, contrast enema, kidney ultrasound. Perfect.
So in essence, I agreed with all of you. I took him immediately for a rectal examination under anesthesia with Pena stimulation to assess the muscle complex. I did redo the kidney ultrasound and bladder ultrasound to be sure there were no residual stones. And here was his examination under anesthesia. He had, on his examination under anesthesia, he had this extensive mucosal ulceration with some degree of prolapse, but more importantly, he had a stricture. The stricture that I noted was just inside the anal skin and extending up the anal canal for an extent of approximately 3 centimeters. The rectum then opens somewhat, and then further up, he has another apparent stricture that's approximately 11 centimeters. Because of this unusual finding on my examination, I performed an on-table contrast enema, and this is the Pena stimulation. I'm worried that this may not work given my success today, but I'm going to try it anyway and hopefully not regret it. Perfect. Okay. Okay, so I guess that the video maybe won't work. Let's see. Yeah. Okay, so no movie. Let me go back to the PowerPoint, hopefully. So the contrast enema showed this stenotic anal canal, and then the second area of stenosis higher up. On my physical exam, I could reach this just with my fingertip, but I couldn't feel more proximally. Because of these findings, I opted to do an MRI because I was concerned that the rectum could have a twist on this area here. The MRI did not document any torsion of the rectum, and this is thought to be caused by some inflammation around the area. So as you can see, he has a very narrow anal canal that extends all the way up to approximately the bladder neck, and then it opens to a more open rectum. You can also notice that he does not have a large fecal burden in the colon, and he does not have significant dilation of the colon. He does have severe pain with passage of stools, and of course, the severe anal irritation that I've shown you. On the video that I was unable to show you, the maximum contraction is noted at this area here, with this being the apparent muscle complex. So when I use the Pena stimulator and stimulate right in this area, this is the area of maximal contraction with the anterior muscle complex bridging right here, and the posterior seeming to be right at the anal opening. So this is where I'm at currently with him, with his parents. He screams and cries each time he has a bowel movement. I took him back for a repeat dilation just to tie him over until I was able to discuss the case with you all. My plan was to divert him because of the severity of the discomfort, pain, and non-healing wounds, but he's had colostomy revision, ileostomy revision, and I'm worried about disrupting further blood supply. So that's why I came to you all for assistance.
Thank you very much, Dr. Neville. When you asked about presenting this case, I thought this was the right forum, because this case is a tragedy of what should not have been done in a patient with anorectal malformation. And I can comfortably say that because I know it was not managed by you, but I think it just gives the perfect example. When you start wrong, things will go wrong all the way. So first, a patient was born with anorectal malformation, and the surgeon decided to do a Hartmann pouch. So the reason why we do a divided colostomy is because we want to know the diagnosis prior to the operation. And we recommend a descending colostomy so you have enough distal bowel for the pull-through. So in this case, the surgeon did a Hartmann pouch. I bet they did not clean the distal bowel, and that's why the patient had bladder stones before 1 year of age. Then they tried to repair this malformation, but because the colostomy was done too shortly, too distal, there was not enough bowel for the pull-through. So what they did is they dissected. The blood supply was probably terrible. Then the anastomose, they pulled through, and now the patient, you can see that the patient has a very narrowing portion because of poor blood supply. They missed the sphincter. The patient has fecal incontinence. So it's a whole sequence of events that should not have happened. So initially, I thought that the stricture was not that severe. And my only question to you is, what Hager dilator were you passing? Just so we have a true idea of how stricture this narrow portion is.
So I was able to dilate with some degree of difficulty up to a 14 Hagar. The initial passage, he was able to accept around a 10 Hagar. The skin dilates easily. The skin is not the problem that is so restrictive. It is that next 2 to 3 centimeters inside the anal canal that is, I cannot admit my index finger.
Okay, so he has a true stricture. So
he has a true
initially,
stricture.
Yeah, because initially I thought that the stricture was not the main problem. And the reality is, in this case, even when the anus was placed outside the sphincter, at this point, it's irrelevant because this patient will never have bowel control. So the operation should not attempt to restore bowel control because that is giving false hopes to the parents. But when the patient has a severe stricture, then a reoperation is needed for the stricture. But as you mentioned, the reoperation on this patient is not going to be a local just anoplasty. This patient will need a full redo pull-through, entering the abdomen and bringing good blood supply, good colon with blood supply down to the anus. So it's going to be a major reoperation. And as you mentioned, he already had colostomy revision, ileostomy closure. So when opening the stoma, I would open a more proximal colostomy as possible and try not to disturb any blood supply. That's when a good laparotomy is helpful because you see which segment can reach the abdominal wall without having to truly interrupt and cut mesenteric vessels. So do you want to comment?
Yes, it would be very nice if I was taking care of this patient. It would be very nice to see the entire colon, the contrast enema that shows how much colon he has, how dilated is the colon, in order to be able to plan in advance the procedure that Dr. Bishop described. And I like to do it open always in order to see perfectly well the blood supply of the colon, the arcades of the colon, in order to select the right piece of bowel that reaches all the way down. And I want to comment also the patient has not only prolapse, but also has granulation tissue in the anus. When they have granulation tissue, that tells you that they have been suffering a lot because the granulation tissue grows there in the area, in the sensitive area of the anus. Because not only he had bad operations, but he had no bowel management. So he has been passing stool into and irritating the anus, and he has been suffering a lot. So that has to be removed and make a wide anus, followed by good bowel management to guarantee that he will be completely clean 24 hours per day. And that's going to change his quality of life dramatically. And that's what That's what justifies our presence in this planet.
Yes, I'm truly grateful. He is miserable, and as are his parents. But you know, with such a difficult case, I do not want to make the wrong decision and complicate a complicated area, make it even worse. My question is, would you divert initially and allow this area to somewhat heal before going back in for a major operation? That was my plan. Divert him proximally and allow all of this inflammation to subside before trying to go back in for a full redo.
Yes, I would definitely divert him first, wait 3 months, and then reoperate on him.
Yes, but before the diversion, it's very important to know how much colon he has. In other words, you might make a stoma that does not interfere with the pull through of the colon, and very much depends on how much colon he has. Because if the length of the colon you estimate that is not long enough, you may have to do an ileostomy. So that is very important to have a whole picture of the entire colon.
Okay, that's great information. Thank you all. Thank you very much.
Thank you. Keep us posted. Poor boy, but I'm glad he found you, and hopefully the family understands that now he's into a better path than what he has been.
They understand. They're just very, very frustrated. And obviously they can't stand to see the suffering he goes through currently. He's miserable.
The urinary function.
Yeah, Dr. Pena is asking, how is the urinary function?
His urinary function is good, and he continues to have preservation of normal erectile function, which I was very concerned about with the number of redo operations that he has had. In fact, I'm worried about doing a redo operation for this exact reason, because of the severity of the inflammation in the area. But to date, he has excellent continence.
That is
for
great.
urinary continence.
He's fortunate.
Yeah, he's fortunate. Yeah. Well, thank you very much. Keep us posted on how he does.
Thank you. I'm so sorry about the technical difficulties.
Oh, no worries. Nobody's fault. So we're now going to move to the next case that is going to be presented by Dr. Fatima Borrayo. Welcome.
Good morning, everyone. We present the case of a 15-year-old male. On December the 6th, he suffered a sexual harassment by his uncle. He was intentionally drugged and he didn't remember the assault. He came to emergency service with fecal incontinence and bleeding through the rectum. We supposed he was injured by a known penetrating object. We decided to perform an exploration under anesthesia. In prone position, we found penetrating injuries at 12, 1, 3, 5, 7, and 11 hours in the perianal area, necrotic tissue, and a acute lesion in the posterior wall of the rectum. How will you perform the repair? 1, first colostomy and then repair. 2, first repair and then colostomy. 3, repair without colostomy. 4, colostomy and delayed repair. 5, other plan. Due to these findings, we decided to perform a laparotomy to create a colostomy. We found a partial injury in the anterior rectal wall 4 centimeters above the peritoneal reflection. Here you can see the descending colostomy with distal mucus fistula. How would you solve this problem? 1, in prone position. 2, in supine position. We put the patient again in prone position. We found injury in the posterior rectal wall with extensive tissular damage and presacral space, destroyed muscular complex and pectinate line. We perform a sagittal posterior approach to expose to and identify the posterior wall of the rectum and muscular complex. Here you can see a lot of necrotic tissue in the presacral space. Here you can see the full thickness injury of the posterior rectal wall. We repaired the posterior rectal wall and we performed the reconstruction, a transrectal approach. After the repair of the posterior rectal wall, we fixed the sphincter. Here you can see the final aspect of the repair. You also can see two drainages at the presacral space. 2 weeks after, the patient presents neurogenic bladder dysfunction, erectile dysfunction. These functional problems in this moment, 2 months after the injury, are partially solved. How much time will you wait for colostomy closure? 1 month after repair, 2 3 months after repair, 3 6 months after repair, 4 it depends, 5 other plan. We would like to perform a distal colostogram in 6 months, an exploration under anesthesia, and then colostomy closure. In this patient, what do you think about perform a Malone procedure? 1, no, it is not necessary. Yes, we will need this procedure in the future. 3, it depends. 4, I don't know. We believe that the patient will present partial fecal incontinence due to severe damage to the anal canal and damage to the sacral nerves. Thank you.
Thank you very much. This is a very sad case to end our session, so we are gonna all be depressed now. But the operation was very good. If I had this patient in front of me, I think I would have done a colostomy and not try to repair under the same scenario, just because of risk of infections. And it's important to remember that most trauma patients, and this would classify as a trauma, as an injury, they do recover bowel control. Because different than patients with anorectal malformation or patients that undergo resection of the colon and damage of anal canal, those patients, they have the colon intact, they have the motility intact, usually a normal motility. So the majority of the patients will not suffer from fecal incontinence. Now, you have a mucus fistula, and by the way, the colostomy was gorgeous. Congratulations for this colostomy. It was beautiful. What you can do is just inject water into the mucus fistula and ask the patient if he can have control. And if he has control, then you know you don't need to do a Malone when you close this colostomy. So this would be my suggestion. Do you want to comment?
Yes, as Dr. Bishop said, I had experience with very severe traumas and clostridiums infections from injections of different substances for prolapse, and patients with trauma respond much better in terms of bowel control because they have a normal sacrum. Now, this patient had an injury that I think injured also the sacrum. I'm not sure about that. But the only explanation that he has no urinary control is that some of the nerves that go to the bladder were damaged. But anyway, in dealing with this kind of operations, it is important to wait until the inflammatory process disappears, which takes between 3 and 6 months before making radical decisions like Malone and like Mitrofanov or that's something like that. In neurogenic bladder, wait at least 6 months to see what's the degree of neurogenic bladder that the patient has, and before making a decision about Mitrofanov or things like that. And after 6 months, I will do a urodynamic study to see how the bladder works and be sure that the urethra was not injured. Now, I was very happy to see that you actually did a transanurectal procedure. In other words, not only posterior sagittal, but you divided the rectum exactly in the midline, and that's exactly what has to be done. And because you did that, bowel control is not affected. So the bowel control may be affected by the trauma. I don't know the magnitude of the trauma.
I don't think they divided. The rectum was divided.
Oh,
in
the
the
rectum
midline.
was divided.
Yes.
But,
During the trauma.
but they continue opening.
No, they just brought the.
No,
That's
you,
what I
you
understood.
opened the posterior wall, am I right? Or you didn't open the posterior rectal wall? You know, did not extend the incision in the rectal wall? That's what I thought.
The posterior rectal wall was completely divided, and
was
we
divided by the trauma.
reconstruct it in the midline, but it was divided because of the trauma. We don't know how the trauma was done.
So the criminal who provoked us damage was very good because he did exactly, he went in exactly in the midline. But anyway, poor boy. But and also during the operation, I saw all that necrotic tissue. And for that, as Dr. Bishop said, I will do the colostomy first and let the patient rest for about 3 to 6 months, and then operate with no inflammatory and no necrotic tissue. That would be my approach. Now we'll see what happens, but I predict that hopefully the patient has bowel control.
Yeah, I would just use the mucus fistula to test and ask the patient to hold, squeeze, go to the bathroom and try. Use it almost as a bowel management through the stoma, just small volumes, like 30 mL through the mucus fistula, and then you'll be able to see if the patient has bowel control or not.
But wait about 3 months.
For sure, yes, wait until there is time. Dr. De La Torre, any comments? No comments.
I agree.
Perfect. So we're gonna finish the meeting a little early. We apologize for the technical difficulties that we had today, but I think we had wonderful cases and I really appreciate all of you joining. We'll see you next month. Thank you, everybody. Bye-bye.